Welcome to Dr. Balaga's podcast for the Curious Doc. Today is July 7, 2026. This video is in a JAMA review titled Alcohol-Related Liver Disease. Why is alcohol-related liver disease important? It is the leading cause of liver-related morbidity and mortality and the most common indication for liver transplant in Europe and the US. How has US mortality changed? Alcohol-related liver disease mortality increased from 6.7 to 12.5 deaths per 100,000 persons between 1999 and 2022. What alcohol exposure defines risk? Long-term intake, about 20 grams per day in women and 30 grams per day in men, can cause alcohol-related liver disease. What is one standard drink? One standard drink contains 14 grams of ethanol. That's about 12 ounces of beer, or 5 ounces of wine, or 1.5 ounces of distilled spirits. What clinical spectrum does alcohol-related liver disease include? It ranges from reversible steatosis to steatohepatitis, fibrosis, cirrhosis, portal hypertension, decompensation, and hepatocellular carcinoma. What literature did the authors search? They searched for PubMed for alcohol-related liver disease, pathophysiology, epidemiology, diagnosis, treatment, and prognosis. What dates were covered? The search included articles published from January 1, 2015 through May 30, 2026. What search terms were used? The terms were alcohol and liver, alcohol and cirrhosis, and alcohol or fibrosis. How are the articles screened? Of the 3,129 identified articles, 735 remained after excluding articles focused exclusively and massilled. What evidence was included? The final review included 114 articles, observational studies, clinical trials, reviews, meta-analyses, guidelines, a consensus statement, and commission reports. What's the article's central clinical message? Chronic heavy alcohol use warrants non-invasive assessment for alcohol-related liver disease and early intervention. How is alcohol-related liver disease or ALD often missed? Alcohol use is underreported because of stigma, cultural factors, recall difficulty, standard drink confusion, or recent reduction. How does metabolic dysfunction change interpretation? Obesity, diabetes, and metabolic syndrome commonly coexist with heavy alcohol use and raise liver and cardiovascular risk. What newer terms overlaps with ALD? Steatotic liver disease includes ALD and metabolic dysfunction and ALD. What is the treatment anchor? Sustained alcohol abstinence is the primary treatment goal across disease stages. Pathophysiology. How does alcohol directly injure the liver? Alcohol dehydrogenase and CYP2E1 generate acetaldehyde, reactive oxygen species, lipid peroxidation products, and NADH-NADA plus imbalance. How does alcohol promote steatosis? Alcohol reduces beta oxidation and increases lipid accumulation, worsened by adipose tissue lipolysis and free fatty acid delivery. What role does the gut-liver axis play? Alcohol causes dysbiosis and barrier dysfunction, allowing microbial products and cytokines to enter the portal circulation. How does fibrosis develop? Hepatocyte injury and inflammation activate hepatic stellate cells, which deposit extracellular matrix. Why does fibrosis matter clinically? Progressive fibrosis disrupts liver architecture, causing portal hypertension, decompensation, and increased hepatocellular carcinoma risk. What was the reported prevalence without correcting underreporting? The ENHANCE study estimated ALD at 0.7%, metabolic dysfunction and ALD at 2%, and MASLD at 31.3%. What happens after correcting underreporting? N. Haynes 2021-23 estimated ALD at 4.59%, metabolic dysfunction and ALD at 4.10%, and MASLD at 28.16%. How common is ALD in hazardous drinking? A meta-analysis estimated ALD prevalence was at 26% among people with hazardous drinking. How common is ALD in alcohol use disorder? The same meta-analysis estimated ALD prevalence at 55.1% among people with alcohol use disorder. How common is cirrhosis after alcohol-related health problems? A meta-analysis reported alcohol-related cirrhosis incidence of 7 to 16% after 8 to 12 years. Risk factors. What are the primary risk factors for alcohol-related liver disease? High alcohol quantity and longer duration are the dominant risk factors. Does the drinking pattern matter? Yes. Daily alcohol use and heavy episodic drinking both increase risk. How quickly can steatosis develop? Steatosis develops within weeks in about 90% of the people consuming more than 60 grams per day of ethanol. Which non-alcohol factors increase risk? Older age, female gender, obesity, type 2 diabetes, viral hepatitis, smoking, and genetic variants increase progression risk. Are wine, beer, and spirits clearly different? Apparently, lower risk with wine may reflect confounding by socioeconomic status and comorbidities. Clinical presentation. How do most patients present early? About 90% without alcohol-associated hepatitis or cirrhosis are asymptomatic. What lab or imaging findings may appear? Liver tests may be normal or mildly abnormal, and imaging may show hepatic steatosis. What suggests alcohol-associated hepatitis? Fever, anorexia, nausea, vomiting, abdominal pain, and jaundice are typical. How may compensated cirrhosis present? Up to 70% are asymptomatic. Others report fatigue or occasional abdominal pain. What suggests decompensated cirrhosis? Ascites, GI bleeding, jaundice, and hepatic encephalopathy should prompt hepatology referral. When should clinicians suspect alcohol-related liver disease? Suspect ALD with harmful alcohol intake, prolonged abnormal liver enzymes, or hepatic steatosis and imaging. What alcoholic thresholds are used clinically? Harmful intake is more than 20 grams per day for women and more than 30 grams per day for men. What alternative causes should be tested? Evaluate viral hepatitis, autoimmune liver disease, hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency when indicated. Why assess alcohol use in obese and diabetes? Concomitant alcohol use is common and may otherwise be mislabeled as MASLD alone. How common are cardiometabolic risk factors? More than 95% of the patients with ALD have at least one cardiometabolic risk factor. Assessment of alcohol use in patients with ALD. How should alcohol intake be assessed? Use a structured, non-judgmental approach and quantify grams per day or drinks per week. Which screening tool is recommended? The Alcohol Use Disorders Identification Test can identify alcohol use disorder. What does phosphatidylethanol detect? It detects recent alcohol consumption within the prior 3 to 4 weeks. Why does ethyl glucuronide detect? Or what does ethyl glucuronide detect? It detects recent alcohol consumption within prior 5 days. How should biomarkers be used? They should complement clinical interview and surveys, especially when self-report is uncertain. Assessment of liver fibrosis in patients with ALD. What is first-line fibrosis testing? Guidelines recommend non-invasive tests such as fibrosis-4 calculated from age, platelets, alanine transaminase, and aspartate aminotransferase. Why is fibrosis 4 useful? It has high negative predictive value and can be calculated by generalists. What is the second line testing advised? A fibrosis 4 score of at least 1.3 should prompt vibration controlled transient elastography or blood based fibrosis test. When should referral occur? Refer for fibrosis 4 above 2.67, second line evidence of stage 2 or higher fibrosis, or persistent unexplained enzyme elevation. How often should low risk patients be rescreened? Guidelines recommend rescreening after 2 to 3 years, especially if alcohol use continues. What is the treatment goal? The goal is alcohol abstinence supported by behavioral therapy and or medication assisted treatment. What determines therapy choice? Choice depends on drinking amount and the presence and severity of alcohol use disorder. What makes management holistic? Care should combine alcohol treatment, liver staging, cardiometabolic risk reduction, nutrition, frailty assessment and follow-up. What changes as disease advances? Care evolves from primary care management to cirrhosis surveillance, complication management, transplant evaluation, and palliative care when appropriate. Why is repeated reassessment important? Alcohol use, relapse risk, fibrosis stage, and cirrhosis severity can change over time. What is motivational enhancement therapy? It is a counselor delivered 4-session motivational intervention with liver health feedback. Did motivational enhancement therapy improve abstinence? Yes. Days abstinence 6 months were 73.1% with therapy versus 59.5% with controls, p-value less than 0.02. Does cognitive behavioral therapy help? Cognitive behavioral therapy plus motivational enhancement improved abstinence days at 2 days from up to 74% versus 48%, p-value equals 0.02. What may severe alcohol use disorder require? Residential inpatient treatment or intensive outpatient programs followed by individual or group therapy may be needed. What is integrated alcohol care? It combines addiction and medical care in the same setting and was associated with lower mortality. Medication assisted treatment to promote alcohol cessation. Which medications are FDA approved for alcohol use disorder? Naltrexone, encapsulate, and disulfiram are approved. Gabapentin, baclofen, and topiramate are off-label. Which drug has trial data in all the cirrhosis, that is alcohol-related liver disease cirrhosis? Baclofen is the only medication tested in randomized trials in patients with alcohol-related liver disease and cirrhosis. What did the baclofen cirrhosis trial show? At 12 weeks, the abstinence was 71% with baclofen versus 21% with placebo, odds ratio 6.3, p-value less than 0.001. When should naltrexone be used cautiously? Use caution in decomposite cirrhosis or alcohol-associated hepatitis. It is safer without cirrhosis or hepatitis. Why avoid disulfiram in ALD? It's not recommended because of hepatotoxicity risk. Are there FDA-approved drugs for ALD itself? No FDA-approved medication currently treats alcohol-related liver disease directly. What is recommended for severe alcohol-associated hepatitis? Prednisone 40 mg daily for 7 days, continued to 28 days if improvement occurs and contraindications are absent. Who may receive prednisolone? Patients with severe disease defined by MADRI discriminant function at least 32 or MELD 3.0 at least 21. When should prednisolone be avoided? Avoided with infection, active GI bleeding or hepatorenal syndrome. How are cirrhosis complications treated? Variceal bleeding, ascites, kidney injury, spontaneous bacterial peritonitis, and encephalopathy are managed as in cirrhosis of other causes. Liver transplant. How common is ALD as a transplant indication. In US, ALD rose from 17% of liver transplants in 2012 to 41% in 2023. How many ALD transplants occurred in 2023? There were 3,505 transplants for alcohol-associated cirrhosis and 658 for alcohol-associated hepatitis. What does MELD 3.0 assess? It estimates transplant need and urgency using bilirubin, creatinine, INR, sodium, albumin, and gender. When should transplant referral generally occur? Patients with MELD score 10 or higher should generally be referred for transplant eval. Is early transplant possible? Yes. Carefully selected patients with severe alcohol-associated hepatitis may be considered without 6 months of abstinence. Which risk factors should be treated? Diabetes, obesity, dyslipidemia, high blood pressure, smoking, inactivity, and poor diet should be addressed. Why treat cardiometabolic disease in alcoholic-related liver disease? Because it may decrease liver-related events and cardiovascular-related events. What lifestyle advice is emphasized? Smoking cessation, at least 150 minutes per week of moderate exercise activity, less sedentary time, and improved diet quality. Which medications are discussed as useful? Statins for dyslipidemia, GLP-1 receptor agonists for obesity and diabetes have supportive safety and efficacy data. What else did the table in this paper emphasize? Cardiometabolic drugs require stage-specific caution, especially in decompensated cirrhosis. Prognosis. What mainly determines prognosis? Fibrosis stage and continued alcohol use determine outcomes. Can early ALD reverse? Steatosis without fibrosis can reverse within weeks of abstinence and may completely resolve. What is the effect of abstinence in cirrhosis? Abstinence reduced liver-related mortality with adjusted hazard ratio of 0.43 and all-cause mortality with hazard ratio of 0.45. Does reducing alcohol use matter? In high-risk drinkers, decreased alcohol use lowered cirrhosis incidence versus no decrease, hazard ratio 0.61. Is low-level drinking safe in cirrhosis? The review notes continued low-level alcohol use in cirrhosis is associated with increased morbidity. Practical considerations. Why is delayed diagnosis common? Shame, stigma, clinician shortages, limited addiction services, and reimbursement or coverage barriers contribute. How often does ALD patients have prior encounters? In Denmark, 40% of patients with alcohol-related liver disease cirrhosis had at least one prior alcohol-related medical encounter. How many had repeated prior encounters? 15% had more than 5 medical encounters before alcohol-related liver disease was diagnosed. Which public health interventions reduce alcohol-related liver disease? Increased pricing plus marketing and access restrictions are the most effective population-level alcohol interventions. What happened after minimum pricing in Scotland and Ireland? It was associated with 12% fewer alcohol attributable deaths and 10% fewer alcohol-related liver disease hospitalizations over 32 months. Limitations. Was the study quality formally assessed? No, the review states that the study quality was not formally assessed. What limits alcohol exposure data? Most evidence relies on self-reported alcohol intake, vulnerable to recall bias, underreporting, stigma, and social desirability bias. Was acute alcohol-associated hepatitis deeply reviewed? No, acute alcohol-associated hepatitis was not discussed in detail. Could evidence have been missed? Yes. The authors state relevant articles may have been missed. How should clinicians interpret the evidence? Use the conclusions as review-level synthesis while recognizing limitations in exposure measurement and evidence selection. Conclusions. Who should be assessed for alcohol-related liver disease? People with chronic daily heavy alcohol consumption should undergo non-invasive testing. Why test non-invasively? Non-invasive testing enables timely diagnosis, fibrosis staging, risk stratification, and intervention. What is the primary therapeutic goal? Alcohol cessation is the central goal. Who should be considered for transplant? Patients with severe alcohol-associated hepatitis or decompensated cirrhosis should be considered for liver transplant. What's the take-home message? Find alcohol-related liver disease early, measure fibrosis, treat alcohol use, reduce cardiometabolic risk, and refer advanced disease promptly. This is an infographic. Hit pause and read at your leisure. Go ahead and read this outstanding JAMA review. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.